Yeah, so now we'll talk about type 2 diabetes. A little bit different problem. Still a sugar problem. So what happens here in diabetes, or type 2 diabetes, is you have your pancreas, right? Your pancreas is making the insulin, right? The insulin being released from the beta cells of the pancreas, which are in the islets of Langerhans. Right? Those beta cells are still working. They're out there, they're pumping out the insulin. Remember, in type 1 diabetes, the beta cells were being destroyed, so they weren't producing insulin anymore. But now, in type 2 diabetes, the beta cells are producing insulin. So what's the problem? The problem is on the cell. So, the problem is these receptors. Remember, when I talked about glucose regulation, the insulin has to come along, right? You got your bloodstream here. Let's just go ahead and draw a blood vessel. And I'm going to draw insulin just like this here. We'll just kind of, right? Insulin's been released from the beta cells, like I said. It says, oh, something sweet, release the insulin. And so now it comes down here and it gets pushed out of the blood vessels into the interstitial area. And of course, there's not just one cell, there's millions of them. But this insulin comes up here and it fits, it's a triangle, right? So it fits right into that receptor. Now remember, when we were talking about glucose regulation, see, so it's putting right into that receptor. So remember, when we were talking about glucose regulation, once that fits in the receptor, it makes the cell membrane permeable to glucose. Well, the inner mechanisms aren't working right, aren't working well, so that comes in there and it's not making the whole cell membrane permeable, right? Maybe if this is progressed for a while, it might just be making maybe from here to here permeable. So glucose can come along. Let's make glucose purple. Glucose can come along and it can get through these areas, but it can't get through the rest of it. Whereas in a healthy person, once that lands there, glucose can just come into the cell from all over, right? And this is a progressive disease. As time goes on, maybe at first then that insulin lands in there, glucose can get in most of the cell, but there's an area, the membrane, where it doesn't get in. And then as it progresses, well then maybe a little bit later, when an insulin lands on one of these, maybe half of the membrane will be activated and the rest of it isn't. And then as time progresses, maybe at the end, it's like I showed here, just that little area there is, lands on there, and only letting glucose in that little spot, that little. So that's insulin resistance, is what we call that. So it's just not working as well with the membranes. The insulin is there, it's just not getting into the cell. It's just not making the cell permeable to glucose like it should. It should be opening up channels and allowing glucose in, but it's not doing the job like in a healthy person. So what happens with that? Well, it's going to be kind of the same thing. Your blood sugar is going to start going up. Now, on a type 1 diabetic, it hit them pretty fast, right? By the time they noticed it, they might even been in ketoacidosis. But this guy here, the symptoms come on slowly, right, over time, because insulin does a lot of damage when it's high. So the fact that your glucose is getting higher, you might be starting to get some circulatory problems, some visual problems and stuff like that, right? Some heart problems. You see the discoloration in your feet, or numbness and tingling in your feet, stuff like that. It's all coming on slowly and you're not really even sure why you're getting that. You go to the doctor and your glucose level, your blood glucose is okay, It's like it's okay, so they don't really know that this is going on. Now the reason it's okay is because your pancreas is working overtime. Those beta cells are just cranking out the insulin, because when it's not maybe we're to the point where only half of the cell is being activated. And then it takes more insulin to come in and land in other places to get more of the cell to be activated. So this progresses, your pancreas is working harder and the beta cells are really cranking out a lot of insulin. So you actually have hyperinsulinemia, right? High insulin in your blood. So at this point here, you're not missing insulin at all. You've got a lot of insulin out there because it takes a lot of insulin in order to get these cells fed with glucose, which is what every cell needs. So what are you going to have? Your blood glucose level might be normal, but you've got a lot of insulin in order to maintain that normal level. As time goes on, though, more of these, it progresses, and the resistance is getting worse. And a big thing is those beta cells that are working so hard in the pancreas, they wear out. They start wearing out and dying off because they can't keep up, right? And they're just working themselves to death. So you start running low. So you were okay. You were able to maintain a normal glucose level when you were putting all that insulin out, but as those beta cells start dropping off and dying, your insulin level drops off. Can't put out enough insulin to keep your blood glucose level in control. Now the first thing that you'll see is that glucose level will start climbing up. It might be in the high normal, right? So it might be in the high normal because you're still got enough, you're putting out so much insulin out there that the glucose is getting in here. But as they start dropping off, you'll see, and they call that pre-diabetic. They'll be in the high normal, and that by definition, by the book that I was reading, which is 3 years old, by definition they say pre-diabetes can be diagnosed if your blood sugar has been between 100 and 125. That seems there's some real overlap there because normal now, they say in the same book, is 70 to 110. So if you're over 110 twice, they can diagnose you with diabetes. There's probably other circumstances that the doctor is looking at, but anyway, that's the definition. And now we know what prediabetes is. That means that you are maintaining a blood glucose level in the normal or near normal range, right? It might be high normal, might be low abnormal, but in that range. So you're maintaining it in that range, but it's taking a lot of insulin to do it, right? That's pre-diabetes. That's where you want to stop. That's what you want. You want to stop it right now. If you can lose weight or do whatever it is that's causing that, you're drinking 10 Cokes a day or something like that, stop it now so you don't lose any more of those insulin cells. If you can save those insulin cells and lose the weight and decrease the need for glucose in your cells, the cells that are left might be able to do the job, and you might be able to avoid being diabetic or becoming diabetic. So, so that's a very important stage, and that's why we treat that stage now, and we'll talk about that later. But anyway, that's where we're at now. This has gotten worse. You're losing pancreatic beta cells, and as you lose too many of those, you're not going to be able to maintain your blood sugar anymore. And that's the problem with type 2 diabetes. So as the type 2 diabetes progresses, you end up with the problem of insulin resistance, right? That was your initial problem, and then you start putting out too little insulin. Now you have a double problem, right? So, right, the resistance, so the cells aren't responding to the insulin, and you don't have enough. You need more than usual on insulin, and you've got less than usual because too many beta cells have died out. They used to call it adult onset because it was only older people that could get this. They didn't think kids could get it. Well, they find out now that kids can get it because kids are eating so much junk that they're wearing these guys out way before they get old. I mean, we've got 9, 10-year-olds that are type 2 diabetics. Unheard of when I was younger. Unheard of just 20 when I started
when I started nursing, first 5 years that I was a nurse, somebody said we're going to be seeing kids with type 2 diabetes. I said, no, you mean type 1, right? Because type 1, yeah, that can happen. It does happen. That's usually when they find out. But type 2, that's not possible. That's what we thought, but that's not the case, and we're proving it. Yeah, you can screw up a good thing if you really work on it. So now, what's going to happen here? I'll talk about. They have a different thing. I talked about ketoacidosis. I'm going to talk about something else here. Hyperosmolar, hyperglycemic, non-ketotic. Hyperosmolar, hyperglycemic, non-ketotic, I think it's syndrome, HHNS, yeah. And some of them leave off the, I've seen that a lot of the newer books leave off the N, and they'll just call it hyperosmolar, hyperglycemic syndrome instead of hyperosmolar, hyperglycemic, non-ketotic, and they leave the non-ketotic out because sometimes you might have ketones, but really I like having the N in there because it really tells you what's going on, or what the problem is. The last time I talked about the ketones, why did you have ketones in type 1 diabetes? You had them because the cells were starving, and we went to the alternative method, or alternative fuel, I should say. But in here, the cells are hungry, but they're not starving, right? So they're getting just enough. Maybe you've got to the point there where you can get. I need my blue marker, man. Where's my hell? I noticed that when I lost my pen, I put it on pause, and then I didn't take it off pause. I was just looking at the thing, and I thought, hell. Brought up HHNS or HHS, and I put it on pause, and my whole long explanation. I sat there talking to the damn camera, and nothing was being recorded. So I thought I better splice this in. So that's why I'm in a different shirt, and the lighting's different, and probably the angle is different, whatever. But anyway, I'm going to talk about it. I'm going to put this in here so that I can explain what HHNS is. And I think I need one of these guys here, but HHNS is a lot like ketoacidosis, except in ketoacidosis, the cells are starving. Like I was saying before, the cells are hungry. They're yelling for sugar, more sugar. Your sugar levels are climbing. Cells don't have to go into starvation mode, and the cells aren't resorting to burning the alternate fuel source, right? They're still getting enough glucose in there that they haven't resorted to that, so you don't end up with the acidosis part, right? But you do have the hyperosmolar part. If you remember when I was talking about ketoacidosis, you get all that blood glucose in there, and I was talking about you had the nephron here. Right, so you get this nephron coming here like this, collecting tubule down here, and then you have when you get and you got your glomerulus here, and your artery coming in, artery going out, you get the urine coming in here, right, it comes in here, the blood comes in here, it pushes real hard, it pushes filtrate, plasma, and all the little stuff that can fit out here gets in here, comes through like this, right on out, and out is urine. Well, when you have this hyperosmolar, you have what's supposed to happen is all the blood glucose that comes in here, you're supposed to reabsorb it all, right? Because we don't want to lose all that glucose. It's our energy source, so we don't want to be peeing our glucose out, so we reabsorb it all. And we fail to do that. We fail to get it all out when you have when you have hyperglycemia. When it's really, really high, you reabsorb what you can, but the rest of it goes straight on through and gets peed out. And unfortunately, that means that down here you have all this blood sugar in the filtrate. So it's got a high osmotic balance. What does fluid do? Fluid goes from an area of lower concentration of solutes into an area of higher concentration of solutes, right? So it's going to go into, so what happens is you get this here, it's very osmotic, so you, instead of having your fluid move back out and you're reabsorbing most of your water, the water just stays in there because all of this sugar is holding it in there, comes through and you just pee it right out. So you have the hyperdiuresis, right? So you have this high amount of diuresis happening, so you're losing a lot of fluid, and you've also got this high osmotic balance in your blood because you've got all of this sugar in your blood, and it's creating a high osmotic balance in the vascular space. So you get a lot of symptoms. Or what happens is you get fluid shifts from your extravascular space into your intravascular space, right? So in other words, from out in the skin area into the blood vessels. So it goes. So you get all this fluid shifting into the blood vessels, and that includes a person's brain, right? So what happens here is you've got so many solids, right, in here. This is your osmotic pressure in here. You've got all this sugar out here, right? So you got so much sugar out here in your vessels and stuff. You've got a lot higher concentration of solids out in here. So fluid shifts from your cerebral space here out into the vessel. Right, and when it shifts out there, then you get the brain cells shrinking, and so you end up with these symptoms, neurological symptoms. It's often will mimic a stroke. They might have one-sided, hemiparesis or paralysis on one side, slurred speech, confusion. They get all this stuff, comatose. So that's why when somebody comes in and we suspect a stroke, one of the first things we'll do is check their blood sugar, right? Because a lot of times blood sugar being off is going to mimic a stroke. So, but anyway, with this hyperosmolar stuff, that's what happens. They can have seizures, right? All that kind of stuff. But they're peeing like crazy. They're thirsty. They got all of these things kind of going on, very similar to ketoacidosis, but it's not ketoacidosis, and you have to know the difference. And the reason you have to know the difference is because the treatment can be a little different. You're not going to be treating acidosis because they're not acidotic. So you want to know. You will be treating acidosis. You might be giving them bicarbonate or something. You don't want to do that with these people. They're not acidotic. You're gonna put them into a acid-based problem by treating them for acidosis if they don't have acidosis. Unfortunately, we don't usually treat acidosis unless we've done ABGs and we've confirmed that they're acidotic. They have the osmotic problems, they have the osmotic diuresis. You're going to treat them. When you treat them, you're going to give them some fluids because they got all this fluid loss going on. You're also going to give them some insulin, right? So fluid replacement's going to take quite a bit. Now you got to remember, they're hyperosmotic right now, right? So you're going to want to try to dilute them down a little bit. So an option for fluids very often is the 0.45% sodium chloride, right? And we just call that half normal saline. Is what they usually call it. But so you might give that, right? Because that will dilute them down faster. Some docs will just go with 0.9, right? 0.9%. There's a zero out here too. Sodium chloride, and they just call that normal saline, which hopefully everybody knows. So, and you can treat them with that, even though because you got to remember they have hyperosmosis, all right? They're at high osmotic pressures there. So giving them an isotonic fluid like normal saline will still be correcting them because it's like a hypotonic solution while it's in a really hypertonic system, right? So I mean, it can still dilute them down to normal, but the half normal saline would do it a little bit faster and with a little bit less fluid. Sometimes even later on, if you've brought them down and you've brought them down kind of fast, they might even switch to something with some dextrose in it, like D5, just to stop them from crashing. You don't want to bring their system down too fast. Too fast, you don't want to correct the osmotic balance too fast. You don't want to correct the sugar too fast. For one thing, if you correct this real fast, boom, right, and you knock this down, you got to remember this has been collected. The sugars have come in here trying to balance it. So it's brought some sugar in here. Now you've just corrected this real fast, faster than what this can change its balance back to where it should have been. So now you can go from the problem of the fluid shifting out to a problem with the fluid shifting in, and then you end up with increased intracranial pressure. Right, and when you get that, you're going to get neurological problems, right? So you've just brought them from one problem and then to another, right? So that's what you want to avoid, and that's why you do it slowly. That way, as you dilute this out, this dilutes out with it, right? And they can stay even. You want them to be able to stay even in their pressures. So. And another thing is, with these guys, same thing with ketoacidosis, you really got to watch that potassium, all of their electrolytes really, but you've got a system that has just been peeing everything out faster than when it can reabsorb things, and now you are hemodiluting them because you're trying to replace all of that fluid, and you really have to watch what you're doing to the electrolytes. And you got to remember, if you're giving potassium, that potassium is going back into cells, right? So you've got that shifting into cells because insulin causes glucose to shift into cells, and it also causes the potassium to shift into the cells. So you've got to watch the potassium level. If they were normal, you got to watch that they don't end up hypokalemic. Very, very common for them to end up with a low potassium like that. You'll just watch that, and maybe you'll have to put some potassium in with the fluid or something, and then run that one at a slower rate. That'll just take the order. You'll see what the doc ends up wanting to do in a case like that. And I think that's probably all I really got to say there about HHS. It's in your book too. And I looked in your book, and it's HHS in your book. The book I had before was HHNS, so you never know which one, but which one they're going to use. I think most of the newer books, I think they're going to just dropping the non-ketotic out because sometimes you have ketones, so they think that could be misleading. Although to me, it really tells you exactly what it is. This is not a ketoacidosis problem. This is a hyperosmolar problem. All right, thanks.